COPD, pulmonary disease, hospice eligibility. COPD, pulmonary disease hospice eligibility, Medicare LCD, and case study parish health systems, eligibility training. Medicare LCD, required criteria. Severe chronic lung disease, must meet all three. Patients presenting with hospice-eligible pulmonary disease often exhibit a progressive decline in both comfort and functional ability. Disabling dyspnea at rest is a hallmark indicator, reflecting the body's diminishing capacity to maintain adequate oxygenation without significant distress. These patients typically demonstrate little to no response to bronchodilator therapy, signaling that the disease has advanced beyond the point where standard interventions can provide meaningful relief. As a result, functional capacity becomes severely compromised. Patients are often confined to bed or chair, experiencing profound fatigue and a persistent, debilitating cough that further limits their ability to perform even the most basic daily activities. Together, these symptoms paint a clear clinical picture of end-stage pulmonary disease and serve as critical markers when evaluating a patient's eligibility for hospice care. A clear indicator of end-stage pulmonary disease progression is the escalating frequency of acute care encounters and hospitalizations. As the disease advances, patients begin requiring increasingly frequent emergency room visits, office visits, and home nurse visits, reflecting a growing inability to manage symptoms through routine care alone. This pattern of escalating utilization is often accompanied by a rise in hospitalizations specifically related to pulmonary infections and respiratory failure, signaling that the patient's condition is no longer responding adequately to conventional treatment. Each subsequent hospitalization typically results in diminishing recovery and a shorter return to baseline, painting a clear clinical picture of a disease trajectory that is progressive, irreversible, and consistent with a terminal prognosis. These patterns of disease progression are critical clinical markers that nurses should recognize and document when assessing a patient's eligibility for hospice care. Objective clinical evidence gathered within the preceding 3 months plays a critical role in supporting hospice eligibility for patients with advanced pulmonary disease. Laboratory and diagnostic findings that meet hospice criteria include documented hypoxemia, defined as a partial pressure of oxygen below 55 mm of mercury or an oxygen saturation of less than 88%, indicating the lungs are no longer able to adequately oxygenate the blood even at rest. Additionally, the presence of hypercapnia, characterized by a partial pressure of carbon dioxide greater than 50 mm of mercury, reflects the body's declining ability to effectively eliminate carbon dioxide, a hallmark of severe and irreversible respiratory failure. When these objective findings are present alongside clinical symptoms and functional decline, they provide strong, measurable, and documentable evidence that a patient's pulmonary disease has reached an end-stage trajectory consistent with a terminal prognosis. Nurses should ensure these values are accurately obtained, clearly documented, and included in the hospice eligibility assessment to support a complete and defensible clinical picture. While not required to establish hospice eligibility, certain additional clinical findings can significantly strengthen the supporting documentation for patients with advanced pulmonary disease. The presence of cor pulmonale, a condition in which chronic lung disease leads to right-sided heart dysfunction, serves as a powerful indicator of severe and progressive cardiopulmonary compromise. This may be further supported by clinical or echocardiographic evidence of right heart failure, confirming that the cardiovascular system has been significantly impacted by the underlying pulmonary disease. Nutritional decline is another important supporting marker, with unintentional weight loss exceeding 10% of body weight over the preceding 6 months, reflecting the profound metabolic burden that end-stage pulmonary disease places on the body. Additionally, resting tachycardia greater than 100 beats per minute suggests that the cardiovascular system is working harder to compensate for inadequate oxygenation, further underscoring the severity of the patient's condition. When present alongside primary eligibility criteria, these supporting findings create a comprehensive, well-documented, and clinically compelling case for hospice eligibility that nurses should actively assess for, clearly document, and communicate to the interdisciplinary care team. Thorough and accurate documentation is the cornerstone of a strong and defensible hospice eligibility determination for patients with advanced pulmonary disease. At minimum, the clinical record must include arterial blood gas results or pulse oximetry readings obtained within the preceding 3 months, as these objective measurements provide the quantifiable evidence needed to confirm the presence of hospice-eligible hypoxemia or hypercapnia. All emergency room visits and hospitalizations related to pulmonary disease should be carefully documented with specific dates, as this pattern of escalating acute care utilization paints a clear and compelling picture of disease progression in declining clinical stability. The patient's current oxygen requirements must be clearly noted in the documentation, including the prescribed flow rate, frequency of use, and any documented episodes of desaturation with activity, alongside a specific notation of the patient's response or lack of response to bronchodilator therapy, which speaks directly to the irreversible and refractory nature of their airway disease. While not required to establish eligibility, pulmonary function testing demonstrating a forced expiratory volume in 1 second of less than 30% of predicted provides powerful and objective supporting evidence of severe, end-stage obstructive lung disease that significantly strengthens the overall eligibility determination. Nurses should approach hospice eligibility documentation with the same precision, thoroughness, and clinical rigor they bring to every aspect of patient care, because complete, well-supported documentation is what ensures every qualifying patient receives the compassionate hospice care they deserve. This case study centers on a 71-year-old male with a confirmed diagnosis of end-stage chronic obstructive pulmonary disease and a significant 50-pack-year smoking history, having quit 2 years prior to this assessment. Despite receiving maximal medical therapy, the patient has experienced a continuous and progressive decline in pulmonary function and overall quality of life, with no periods of meaningful or sustained improvement. His clinical history is marked by multiple hospitalizations resulting from acute COPD exacerbations and pneumonia, each admission further eroding his already critically compromised respiratory reserve and leaving him with a progressively diminished ability to return to his prior functional baseline. His pulmonology team has exhausted all available medical and surgical treatment options and has determined that no further interventions are capable of altering the course of his disease. This constellation of findings, end-stage disease with a significant smoking history, progressive functional decline despite optimal medical management, a pattern of recurrent acute hospitalizations, and a specialist determination that curative options have been exhausted, establishes a clear, well-supported, and clinically compelling foundation for hospice eligibility evaluation and referral under Medicare LCD criteria. Objective clinical data obtained within the past 3 months provides compelling and measurable evidence of the patient's severely compromised pulmonary function. An arterial blood gas obtained on January 15, 2026 revealed a pH of 7.38, a partial pressure of oxygen of 48 mm of mercury, falling well below the hospice eligibility threshold of 55 mm of mercury, and a partial pressure of carbon dioxide of 58 mm of mercury, confirming the presence of significant hypercapnia consistent with end-stage respiratory failure. Pulse oximetry readings have consistently ranged between 82% and 85% on room air, far below the 88% threshold that defines hospice-eligible hypoxemia. The patient requires continuous supplemental oxygen at 4 liters per minute at rest and experiences significant oxygen desaturation with even minimal physical activity, reflecting the profound limitations imposed by his advanced disease on his ability to perform basic daily functions. Pulmonary function testing further confirms the severity of his condition, with a forced expiratory volume in 1 second of just 22% of predicted and a forced vital capacity of 48% of predicted, findings that are consistent with severe, irreversible obstructive lung disease at an end-stage level. Taken together, these objective findings provide strong, well-documented, and clinically defensible support for hospice eligibility and should be clearly included in the patient's hospice assessment and referral documentation. Objective clinical data collected within the past 3 months provides powerful and measurable confirmation of the patient's severely deteriorated pulmonary function and strongly supports hospice eligibility under Medicare LCD criteria. An arterial blood gas performed on January 15, 2026 demonstrated a pH of 7.38, a partial pressure of oxygen of 48 mm of mercury, significantly below the hospice eligibility threshold of 55 mm of mercury, and a partial pressure of carbon dioxide of 58 mm of mercury, confirming clinically significant hypercapnia consistent with end-stage respiratory failure and the body's inability to effectively eliminate carbon dioxide. Continuous pulse oximetry monitoring has consistently recorded oxygen saturation levels between 82% and 85% on room air, values that fall critically below the 88% threshold established by Medicare LCD criteria for hospice-eligible hypoxemia. The patient is currently dependent on continuous supplemental oxygen at 4 liters per minute at rest and experiences significant and rapid oxygen desaturation with even the most minimal physical activity, underscoring the profound degree to which his pulmonary reserve has been exhausted. Pulmonary function testing reveals a forced expiratory volume in 1 second of just 22% of predicted and a forced vital capacity of 48% of predicted, findings that are not only well below the 30% FEV1 threshold that supports hospice eligibility but confirm the presence of severe, irreversible, and end-stage obstructive lung disease. These objective findings, taken together, form a clinically compelling, thoroughly documented, and fully defensible foundation for hospice eligibility that nurses should ensure is clearly captured and communicated in every aspect of the patient's hospice assessment and referral documentation.
Over the past 6 months, the patient has had frequent acute care utilization, including visits on 7/20, 8/15, 9/30, 11/10, and 12/28. Hospitalizations during this period include a 7-day admission in July 2025 for pneumonia, a 5-day stay in October 2025 for a COPD exacerbation, and a 9-day ICU hospitalization in December 2025 for respiratory failure requiring BIPIP support. The patient's functional status reflects significant decline, with a PPS of 40% and a predominantly bed-to-chair existence. She requires assistance with activities of daily living and has experienced notable nutritional deterioration, losing weight from 168 to 148 pounds, a 12% loss over 6 months. On exam, the patient is in severe respiratory distress at rest, with pronounced accessory muscle use, decreased breath sounds with wheezes, and a heart rate of 106. Physical findings are consistent with core pulmonale, including jugular venous distension and 2+ peripheral edema. She also demonstrates classic signs of advanced COPD, such as a barrel-shaped chest and pursed lip breathing. The patient meets hospice eligibility criteria due to persistent dyspnea at rest with minimal bronchodilator response and markedly reduced functional capacity, alongside clear evidence of progressive disease reflected in 5 visits and 3 hospitalizations. Objective testing confirms severe respiratory compromise with hypoxemia, PO248, and hypercapnia, PCO258. Additional indicators, including core pulmonale, significant weight loss, and tachycardia, further support the presence of end-stage pulmonary decline. Best practice documentation should use clear, eligibility-focused language, such as 71-year-old male with end-stage COPD, FEV1 22%, demonstrating disabling dyspnea at rest and severe hypoxemia, PO248, and hypercapnia, PCO258, on room air despite maximal therapy. Progressive decline evidenced by 5 visits and 3 hospitalizations over 6 months. PPS 40%, core pulmonale and 12% weight loss further support limited prognosis. Overall clinical picture consistent with a life expectancy of 6 months or less. Common documentation errors include failing to provide an ABG or pulse oximetry reading within the past 3 months, documenting oxygen saturation while the patient is on supplemental oxygen instead of room air, and omitting a complete list of medications or evidence of maximal therapy. Additional issues include missing dates for visits and hospitalizations, not documenting dyspnea at rest, and overlooking key clinical indicators such as core pulmonale, all of which weaken eligibility support.
To meet COPD hospice eligibility, documentation should clearly show that the patient has severe symptoms at rest, is experiencing progressive decline, and demonstrates objective hypoxemia or hypercapnia on recent testing. It should also reflect functional decline with increasing dependence, frequent acute episodes such as visits or hospitalizations, and evidence that the patient is on maximal medical therapy with minimal response, establishing a poor prognosis and limited treatment options.